Here we have DM. She's 58. She came in with an onset shortness of breath and sharp chest pain. She is 10 days post left total knee arthroplasty, and her findings consistently shows that she has a primary diagnosis of pulmonary embolism secondary to the left leg DVT. Okay, so under normal physiology, the pulmonary circulation delivers deoxygenated blood in the right ventricle to travel through the pulmonary arteries to the alveoli for gas exchange. So in DM's case, several postoperative risk factors include recent surgery, the immobility, obesity, and poor anticoagulant adherence contributed to the venous stasis and the hypercoagulability. So this led to the thrombus formation in the deep vein to the left leg, which subsequently embolized to the lungs. The embolus lodged in the right main pulmonary artery, causing an acute obstruction to pulmonary blood flow. This obstruction results in a sudden increase in pulmonary vascular resistance, placing the strain in the right ventricle and leading to poor perfusion to ventilated alveoli. As a result, the ventilation perfusion mismatch develops, leading to hypoxemia. So this explains why DM's dyspnea, tachypnea, and oxygen saturation was low. So her tachycardia and hypotension reflects the compensatory responses to decreased cardiac output and impaired pulmonary circulation, while her lightheadedness reflects poor reduced cerebral perfusion. Pleuritic chest pain results from irritation from pleural structures near the embolus. Thomas et al. Described that pulmonary embolism is a sudden increase in pulmonary vascular resistance, which leads to the right ventricular strain and impaired oxygenation, leading to patients to commonly present with hypoxemia, tachycardia, and troponin, and mild troponin elevation. Okay, so the clinical manifestations, we see in her lab findings, the D-dimer is 2.1 milligrams, slightly elevated, and that indicates that she has active clot formation and breakdown. The elevated troponin levels indicates right ventricular strain rather than MI. In PE, increased pulmonary vascular resistance increases the right ventricular afterload, which leads to myocardial injury. Okay, her lab value lactate is elevated, which indicates that her body is under some sort of stress, and in this case, it's poor oxygen delivery. Her ABG, arterial blood gas lab, shows that she has respiratory alkalosis and with hypoxemia, and this occurs because of low oxygen levels. And this ultimately stimulates the respiratory drive, leading to hyperventilation and excessive carbon dioxide elimination, which raises the pH. The CT pulmonary angiography confirms that she has a filling defect in the right pulmonary artery, which confirms the PE. The RV-LV ratio of 1:1 represents that she has a her right ventricle is bigger than the left ventricle, which confirms that she has early sign of a right ventricular strain. Doppler ultrasound shows her non-compressive left popliteal vein, covering the presence of DVT as an embolic source. Conditions like MI or pneumonia can mimic these symptoms, but her combination of pleuritic chest pain, hypoxemia, elevated D-dimer, and imaging supports that PE is the primary diagnosis in this case. Okay, so nursing priorities, the first one is the risk of hemodynamic stability from obstructed pulmonary blood flow and resulting right ventricular strain. When the RV must pump against a sudden increase in pulmonary vascular resistance, it can dilate and fail, reducing the cardiac output. So nursing action here is continuous cardiac monitoring and frequent blood pressure checks. And we can also do close assessments for any signs of RV failures, such as tachycardia, hypotension, and JVD, jugular venous distension. And second priority here is impaired gas exchange from ventilation perfusion mismatch. So in the PE, alveoli receives the air but not blood flow, leading to hypoxemia and increased work of breathing. And the nursing interventions here would be monitor oxygen, monitor respiratory rate, work of breathing, and initiate oxygen therapy as needed and as ordered by the physician. So the key intervention here is prompt anticoagulation therapy to prevent the clot from growing. Antibiotics and diuretics are not indicated in this case because she does not have an infection or fluid overload. Fagioni AL 2025 emphasizes early anticoagulation therapy because it stops the existing clot from growing bigger and prevents the new clots from forming in the legs. Now, reflecting in this case shows how understanding the PE pathophysiology guides the nursing clinical judgment, recognizing that hypoxemia, tachycardia, and hypotension stem from impaired pulmonary perfusion helps nurses anticipate deterioration and intervene early. It also highlights the importance of post-operative venous thromboembolism prophylaxis, early mobilization, and patient education on anticoagulant adherence. Effective discharge teaching and follow-up are essential as well to prevent the complications of PE. Thank you.